whether we don't need to do a lot more work at the beginning of the process in building the confidence of patients in the advice their clinicians give them, and in not just looking for feedback, but looking for real engagement on the terms on which a clinician and his patient work together. It seems to me that that ought to be at the root of the reforms if we are looking at cultural change and really meeting the needs of the patient. And that for as long as the health service is driven predominantly by a professional approach without the engagement of the patient, we're going to go on having a lot of waste.
Okay.
I'd be interested to hear what the panel have to say about that.
Okay, thank you very much. Well, on this occasion, since we've got quite a few topics, I'll just ask for different contributions, different members of the panel on different ones. The first one, if I may generalise it, obviously you were about community pharmacy, but there's to me, and maybe I'm getting it wrong here, there's a wider question, which is why GPs? Why not anyone else? For example, pharmacists or anyone else. And we've had this before as well. When New Labour came in 1997, they said they're going to replace the internal market with locality commissioning because they didn't think it should just be GPs. Now, in a sense, we could go around these debates and around these racetracks over and over, but do any panel members have a view on, who should actually be doing the commissioning? Okay, the GP CCs are going to hold the budgets, if the Act passes, but who should be involved in, and this is the cultural point, who should actually be doing it? Who should be working together? Andrew? Yeah.
My understanding of the position is that within a GP consortium, it's certainly open to the GPs to work with non-GP members and, for example, community pharmacists and so on and so forth. There seems to be no ban at the moment or no rule that says it's just got to be GPs. And I would have thought that in a lot of areas, GPs would very, very quickly want to take on assistance from community pharmacists as they will from consultants and those who can best advise them.
Okay, thank you.
Yeah, I think also we should just reflect that we have a system which is not the same in Europe, where the entry point into the NHS is through the GP. If you go to France, Spain, Italy, you can see a respirologist, you can see a paediatrician, you can see a cardiologist directly. That's the way the system works there. So we have a system here where every patient is registered with a GP within a population, a local practice boundary. Families are registered with a GP. If you want to see a cardiologist or respirologist, you go through your GP. When a hospital discharges a patient, they say, go back to your GP. And we see a lot of this on a daily basis, with patients walking through our doors, coming back to us, and we're seen to be the entry point, the hub, the focus. So in that regard, I can sympathize and understand why the GP is considered to play an important part in navigating where patients are managed. But clearly, the GP isn't the person who should be spending their time in contracting and in management, and you need to have other people doing that sort of work, and neither should each GP be doing any of the commissioning work. We've always argued that there will be lead GPs in a population who will do that. I don't think you need to have whole systematic reform being proposed to have achieved those aims, but that's the model that we would suggest. But I just want to say one more thing about the compliance. I think one of the most important qualities in a doctor-patient relationship is trust. If the patient trusts the GP and they feel the GP has given them time, is giving them advice in their interest, they're more likely to take the treatment prescribed. And coming now on to GP commissioning, one of the fundamental points that the BMA have always argued for is to make sure that the commissioning budget for GPs is entirely separate from the money they receive to be a GP providing care for patients. We don't want any patient to suspect that the decision of a GP to refer or not to refer is motivated by any sense of making a profit or otherwise. So we're being absolutely clear that that commissioning budget has to be separate. And I think if you can do that, you will have the right trust so that patients aren't going to actually think, well, the GP did not prescribe me this drug because, or prescribe me a cheaper drug simply because he or she had a financial motive to do so. Thank you.
Sean, can I just ask you a question based on that? That's very interesting. And is it, you know, the white paper on my quick reading seems to me to seek to deal with that. And I'd be interested to know if you think that's adequate, because I said it was an irony this morning that the research over the last 15 years has shown that where GPs do commissioning, they commission extended primary care best, and they're not too interested except piecemeal in other things. So paradoxical it is, as a result of that, that's exactly the sort of thing they won't necessarily be commissioning, and that the National Commissioning Board, however it does it, will be doing that. That's partly around the question that they shouldn't be, having this conflict of interest. And so, I mean, the white paper seems to accept your view, but do you think there's any further practical things that would have to be done, for example, so that your fears were allayed, if I could put it that way?
I think we don't have the detail, but I think one of the real tensions is that we are going to be all operating within a financial downturn that the NHS has never witnessed before, and under the QUIP agenda of saving 15 to 20 billion pounds. Now, I don't think any of us have got the detail of how consortia will be performance managed and what financial elements will be in place to try and ensure that consortia work to this financial agenda. So, I mean, we don't have the details, but we certainly would not want to see, for example, payments made to GP practices to reduce their referrals by X%. I mean, that would be the sort of, that would create huge mistrust. And what we want to see is consortia working in a way that is quite separate from the income a GP receives for their general practice work. But I think we don't have the detail at the moment. Thank you.
Okay, thank you. Yeah. So we don't lose it. This question of cultural change, and of course, what we mean by cultural change and whose cultural change. Bernard, clearly, the subtext and indeed the actual content of some of your presentation was about, what can be done in the right cultural circumstances. I mean, is there any, I don't want to put you on the spot, but is there any reflection you'd have, on the cultural change required for the NHS actually to do more of the good stuff that you're talking about?
Yeah, well, there is, and the model that underpins what the Institute does in relation to trying to promote cultural change in innovation, or cultural change in relation to putting quality and safety at the heart of what we do, is based on trying to improve the quality of leadership, including clinical leadership in organisations, is based on using measurement as a way of supporting improvement, is based on the belief that there are a range of tried and tested tools and techniques for improvement which recognise that almost all change is local. I mean, whatever happens nationally is, of course, important, but actually it's right down at the level of the relationship between clinician and patient and the team that provides the care that we see culture that is conducive or inimical to high quality. And that the final key element in that is the quality of relationships between patients and clinicians, between clinicians of different tribes, and also between teams. And all of our work seeks to try and develop and strengthen those dimensions of the delivery of care. Because, as I said earlier, there is no golden age in which I practiced 25 years ago, which all of those things operated optimally to deliver high quality, consistent, safe patient care. We've still got a long way to go in relation to that. And I think when I visit hospitals, you can see very quickly those organisations that have those elements in place and are trying to grow them. Sadly, one of the common things we find is that where there's been a longer tenure of high quality leadership, extending over the life cycle of several of the kind of upheavals that we have commonly in the NHS, it's more common to find that that culture's really got embedded and maintained. And the extremely short length of the tenure of people leading many of our organisations, I think, is a source of substantial regret. And there's good evidence, in my view, that high-performing systems tend to be characterised by having a greater tenure and longevity of leadership.